Welcome everyone to the ISN KDIGO presentation. I'm Brad Rovin and I'll be your host today. We have two excellent speakers, and let me introduce Dr. Heather Reich. She's an associate professor and the Zellerman Chair of Nephrology Research at the University of Toronto. She has a glomerulonephritis group at the university and is an expert in IgA nephropathy. She was a member of the KDIGO Work Group for IgA nephropathy and wrote those guidelines. We also have with us today Professor Vladimir Tesar. He's head of the nephrology division at the Charles University in the Czech Republic. He's also a dedicated investigator of glomerular diseases and was a member of the KDIGO Vasculitis Work Group and prepared these guidelines that he'll discuss today. And he was also the entire work group for the anti-GBM disease guideline. Both Heather and Vladimir do basic translational and clinical research in glomerular disease. They're heavily involved in clinical trials of new therapeutics for glomerulonephritis. I've had the pleasure to work with both investigators on clinical trials as well as translational and basic research. And so I think today you're in for an excellent discussion. Now, just a couple of rules or sort of procedural. We're going to start out with Dr. Reich, and then we're going to go directly to Dr. Tesar, and then we're going to have questions at the end. My job will be to monitor the questions that you submit, and then I will ask them. We can go over a little bit past the hour, but we don't want to go over very far. If indeed there are a lot of unanswered questions at the end, these are going to be stored and monitored, and then they'll be distributed to us, and we will answer them by email. So if you have a burning question and I didn't get to it, don't worry, we're going to try and get to it after the program. So without further delay, Heather, you're on. Thank you.
Perfect. Thanks so much. And thank you to ISN for the invitation to speak today. And I sincerely hope that we can all be together for exchanging academic ideas in person in good health very soon. So it's my pleasure today to discuss the upcoming update in the KDIGO-GN treatment guidelines, focusing on the IgA nephropathy chapter. These are my disclosures, which are important because most of them are related to IgA clinical trials. IgA nephropathy remains a leading diagnosis on virtually every kidney biopsy series and an important global cause of kidney failure. The KDIGO guidelines will be published, the update will be published shortly, and several themes emerge in the IgA nephropathy chapter, prompted largely by new data released since the original version, which is of course exciting and what we want to see in the world of GN, where clinical trials have not been abundant in the past. We have new tools available for prognostication to help target patients at highest risk of progression. The guidelines do acknowledge challenges reconciling efficacy versus toxicity of immunosuppression in IgA nephropathy, particularly trials that have been published since the last edition of the guidelines. And there's also a recognition that I hope it emerges that the community needs to continue to really passionately promote research and innovation to improve the outcomes of patients with IgA nephropathy. In writing the IgA guideline, our fearless leader, John Barrett, and our group really made great efforts to reflect international variation in treatment of IgA nephropathy and to reflect and illustrate the standard of care in countries around the globe. So rather than show a whole series of evidence-based tables, I thought that really the best thing to do would be to focus on a case. And this is a typical patient that I would encounter in my clinic in Toronto in Canada. So this is a 40-year-old woman born in China, and was noted to have proteinuria at the end of her pregnancy at the age of 38. She had limited follow-up postpartum as she was very busy with her family. She was noted to have hypertension at a GP and referred to nephrology for investigation and kidney biopsy. At the time of the kidney biopsy, her blood pressure was 150/90. She had 2 grams of proteinuria per day. Her eGFR was 63, and at the time of biopsy, she was not yet on RAS blockade or immunosuppression. The histologic pattern on her biopsy was M1, E1, and S1 with no tubulointerstitial fibrosis and no crescents. So a first step in treating IgA nephropathy is assessing prognosis, and that's based on data available at the time of biopsy. And in the upcoming chapter, we suggest using a prediction tool that was derived based on the largest and most geographically diverse cohort to date. So the first suggestion, whoops, sorry about that. So if one, the prediction model, is available on qxmd.com. And the first suggestion in the guidelines is entering the data. And if you plug in the data at the time of kidney biopsy, sorry about that, I've just got to get back to my screen, it's very sensitive. At the time of kidney biopsy, you can enter a horizon at which you would like the prognostic information. So in the case of this patient, I enter the data and see that actually at a 5-year horizon, her risk of having of GFR or progression to kidney failure is actually kind of surprisingly high at 20%. Just of interest, if you fiddle with the tool a little bit and you enter the T1 as tubulointerstitial fibrosis, that risk is as high as 36%. And so this really does give some important information regarding the future trajectory of this patient. There are some future research questions. We know that this tool is only validated and derived using values derived at the time of the kidney biopsy. So you can't enter her blood pressure a year later and see what happens. And so the question for future research will be, can we use this over time again or do we need to derive a new equation to provide similar prediction accuracy using variables later in the disease course? We don't yet know how treatment modifies this prognosis, and we certainly should not use this tool to decide what treatment to use, but it's extremely important with respect to engaging patients in their own self-care and discussions about what treatment path to follow. There's an emphasis, as I mentioned, in the guidelines on the knowledge gaps in IgA nephropathy. And so a key step in management is trying to enroll patients into a disease registry. And this is one of the suggested next steps. And fortunately, there are now several international registries developed to better understand the natural history of IgA nephropathy, as well as the biology of IgA nephropathy, and to identify patients who might be candidates for the many clinical trials that are currently running for this disease. And of course, the next step when we start treatment planning is to address modifiable cardiovascular risk factors for disease, modifiable risk factors for disease progression, and these include a lot of cardiovascular risk factors. So there's a pretty clear statement that, of course, we need to make sure that there are no other phenotypes of IgA. Like, this is not discussing patients with RPGN or minimal change. We're talking about simple progressive IgA nephropathy here. But the primary focus of management should be optimized supportive care. In terms of details regarding like what are our targets for optimized supportive care, a lot of these are based upon observational data and are discussed in a general chapter on CKD prevention in patients with GN. And I'll just highlight a couple of points that are different than the last version of the guideline. First, there is a statement suggesting not to combine ACE inhibitors and ARBs. There's no evidence to suggest that it's superior in IgA nephropathy, and in fact, now there's a post hoc analysis of the STOP study that demonstrated no additional benefit of dual blockade, and of course, we're all familiar with the potential for harm. The other new point is that what should be our treatment goal? I think intuitively we all knew this, but now we have strong epidemiologic, clinical data, and data derived from randomized trials from the Kidney Health Initiative work that supports that a goal of therapy is reducing proteinuria to under 1 gram per day. This is a surrogate marker of improved kidney function in IgA nephropathy, and that is the target that's recommended with therapy. And our enthusiasm for and the emphasis on the critical importance of conservative therapy is highlighted by the STOP IgA study. We now have the 10-year data that confirm the initial trial results that the immunosuppression intervention in this study did not offer an advantage over conservative therapy alone. However, probably one of the most important findings of this study is that in the run-in period of 6 months for optimized conservative therapy, at the end of the 6-month run-in period, a third of patients no longer qualified for randomization in the trial, really emphasizing the importance of that run-in period, of course, for clinical trial design, but also for patient care, and the important goals that we can achieve by using less toxic agents. So this patient, she is treated for 4 months with diuretic angiotensin receptor blocker. She had a high LDL, so she was given a statin. And at the end of 4 months of therapy, her blood pressure was 100/70, so she is on maximally tolerated RAS blockade. Her proteinuria, unfortunately, remains 1.6 grams per day, and with the institution of RAS blockade, her GFR is now 50. So, of course, the next discussion is about when and whom we should consider corticosteroid therapy. And we suggest that patients who remain at high risk of progressive disease, despite maximal supportive care, should be considered for a 6-month course of glucocorticoid therapy. And as I'll highlight in a moment, the fact is that the best evidence suggests efficacy and improved long-term outcome in patients who are treated with corticosteroid versus optimized conservative therapy alone. We discuss that the important risk of treatment emergent toxicity must be discussed with patients, particularly in those who have an EGFR under 50. And it's not to say that, you know, an EGFR under 50 is a threshold where you should not treat with steroids, not at all. But the GFR under 50 seemed to be a threshold cut point where in the existing randomized controlled trial, there was a higher incidence of steroid side effects and toxicity. So that just needs to be discussed in detail with patients when we embark on this therapeutic pathway. We suggest using an extreme caution or avoiding entirely in patients with some contraindications, such as severe osteoporosis or uncontrolled psychiatric illness. And again, we don't have data really that help inform us whether steroids are beneficial in patients with an EGFR under 30. So there are, of course, individual considerations and instances where we may consider using therapy in isolated patients with GFR under 30, but this again requires individual discussion. And these data and these recommendations are largely based on high quality randomized controlled trial data from the testing study. As you are likely familiar, there was a run-in phase of 3 months, after which patients were randomized to methylprednisolone or placebo. And the primary endpoint of interest was a composite endpoint of 40% reduction in kidney function or kidney failure or death. And as many of you recall, this study was paused on earlier, and while investigators remained blinded, an analysis group was unblinded to treatment allocation. And the reason why the study was paused early was because of a signal of higher adverse events in the methylprednisolone group. No one would really be surprised that there would be more side effects in patients receiving prednisone compared to a placebo, but what was of particular concern was an excess of infections, particularly PJP, and these were felt to be potentially modifiable SAEs that mandated a change in the protocol that included reduction in the corticosteroid dose, as well as PJP prophylaxis in both groups. And so the study was continued. We are eagerly anticipating the results because recruitment was completed several months ago, and we hope to see the results of the combined and revised protocol. All to say, though, that the primary endpoint, even at the time of early analysis, suggested very strong signal of efficacy. And as you'll see in the survival analysis, the hazard risk of the composite endpoint was 0.37. It was statistically significant. And so we're really anxiously awaiting the results of the final completed protocol. Some additional points about corticosteroids. There are insufficient evidence to support the use of the Oxford classification in determining when glucocorticoid therapy should be commenced. So, for example, you really, just because a patient has crescents is not a knee-jerk reaction to give corticosteroids. That's a work in progress. There are no data to support efficacy or reduce toxicity of alternate day corticoid regimens. I still see patients getting this often, or we're waiting the testing results to see about dose-reduced protocols. And where appropriate, the real risks of corticosteroids can be mitigated, and they can be mitigated with PJP prophylaxis, gastroprotection, bone protection, according to local guidelines. So we're trying to promote some safer use of glucocorticoids. So when we consider this evidence, the treatment algorithm recommends consideration of corticosteroids in patients that have persistent proteinuria over 1 gram per day if the risk-benefit profile is favorable. Given a lack of data in patients with GFR under 30 and suspected higher risk, eGFR of 30 is considered a threshold for treatment, but again, there may be unique patient-specific exceptions. But these are where our best data are available, and we try to make guidelines based on available high-quality data. There was a review as well as some small but well-conducted randomized controlled trials that suggest potential for efficacy of MMF as a steroid-sparing agent or hydroxychloroquine in Chinese populations. And so this is reviewed in tables and highlights potential therapies that have been studied in particular populations, but may require validation in additional expanded populations. Some other practice points that are discussed. There's not much change in the recommendations in terms of treating minimal change variant, RPGN. There's some discussion on pregnancy, and with respect to pediatrics, there's a very thoughtful, nice section of practice points geared towards pediatric population. And specifically, it's suggested that retrospective studies would support use of corticosteroids, that the target blood pressure should be around the 50th percentile, and that should be achieved with RAS blockade. And in patients with 1 gram of proteinuria or more and mesangial proliferation, most pediatric nephrologists will provide corticosteroids. Importantly, this is from the time of diagnosis, which is a little bit different than adults where we have this, emphasize this run-in period. And you'll also notice the language that these are practice points and really describe practice as opposed to firm evidence-based recommendations. So back to our case, our patient received prednisone. She gained weight, had some cosmetic side effects, had a somewhat decent response, 1.1 gram per day, eGFR stable after 6 months, but maybe a bit of an unsatisfactory response. We know she remains at risk of progression. And this highlights real unmet needs in IgA nephropathy in the field of, in the areas potentially of what better conservative therapy could we give her now that she has received a course of corticosteroids? What steroid-sparing strategies might be available to achieve better remission after the induction phase, or maybe even for maintenance. And we cannot deny the toxicity of corticosteroids, emphasizing the need for development of novel treatment agents. And of course, we're going to discuss the DAPA-CKD data, which appear in the discussion on future research of the guidelines, even though the data were actually available at the time of the submission. And specifically, I'm discussing the IgA subgroup analysis of around 260 patients. It was a pre-specified subgroup analysis of the randomized trial. At 32 months, 24% of the placebo group exhibited the primary endpoint. And this is a bit peculiar and a bit unlike the typical studies that we see in IgA nephropathy. So there was a reduction in the composite endpoint of having of GFR, kidney failure, death, or death due to cardiovascular disease. But the placebo group did particularly poorly and very much unlike our corticosteroid studies. 3 participants died, but primarily cardiovascular, not other causes of death. Again, a bit unusual. There was no run-in period in this study, so we can't definitively say how much of an advantage there was over truly optimized RAS blockade, lipid management, blood pressure. And there were blood pressure effects, which require further study, was the SGLT2 inhibitor benefit in addition or independent of the blood pressure lowering effects. And finally, we really don't have data about whether it's safe to use SGLT2 inhibitors concurrent with high-dose corticosteroids. And I have particular concern about this given the potential for mycotic GU infections. And so this just requires future study. And I don't want to sound too negative. I do think these medications have a very important role in CKD. I think the question for future research is where they fit in the series and trajectory of therapies for IgA nephropathy. Do they really address underlying immunopathogenesis of the disease? Unlikely, but we don't know. And we do have, and finally, we do emphasize research in the guideline. These are living documents. We hope to have updates. We are enthusiastic and eagerly awaiting the phase 3 studies of the Nefecon trial, which suggests that oral sustained targeted release budesonide may have advantage over placebo and potentially less toxicity. So we're waiting for those phase 3 data and data regarding SGLT2 inhibition for further study, endothelin inhibitors, and also, as I highlight on the right here, a very active series of studies currently looking at modulation of complement cascade and how these agents may modify disease progression. And on the left side of the slide, April BAF, so looking at cytokines and how cytokines may be affected. So there are important new observational data and clinical trials that inform the KDIGO guidelines, an emphasis in targeting patients at risk and knowledge gaps, and important new developments that may impact future revisions. And thank you again for the opportunity to speak, and look forward to discussion afterwards.
So I hope that everybody hears me and sees my presentation. And my today's aim is to present some data on ANCA-associated vasculitis to compare what was in older guidelines from 2012 and what is in new guidelines 2021. These are my disclosures. And here you see that ANCA-associated vasculitis, fortunately, is an area where we have really many clinical studies, and that our recommendations are usually based on a very good evidence. You see that there were many trials already in 2012, and there were several other trials which were published within 2012 and 2021, and which were mostly included into other recommendations for 2021. I will discuss 4 different aspects of the recommendations: initial therapy and treatment of relapse, plasma exchange and its role in the treatment of ANCA-associated vasculitis, maintenance therapy, and something which is a bit beyond guidelines, and this is complement inhibition. So starting with initial therapy and relapse, I would like to go back and remind you of the fact that really Wegener's granulomatosis, or what is currently called ANCA-associated vasculitis, was really a disease with very poor outcome, with median survival of 5 months and with 1-year mortality of 82%. And it improved only with the introduction of cyclophosphamide gradually during the 1970s, 1980s. But the problem with this treatment always was that it was very much effective, but also very toxic. So you see here on data from UBAS that currently, or 10 years ago when the data were published, patients with ANCA-associated vasculitis in the first year of their treatment are no longer dying so much because of active vasculitis. It was less than 20%, but mostly because of some complications of treatment, such as infections, and later on also because of cardiovascular disease and malignancies, especially after the first year of treatment. So it was always clear that we should do something to minimize cyclophosphamide exposure, and there were 2 studies in which we participated in the 1990s, how to do so, by early switch from cyclophosphamide to azathioprine, and by using cyclophosphamide pulses with about 50% lower cumulative dose of cyclophosphamide instead of oral cyclophosphamide. In short term, these studies were effective, and there was no increase of relapses with reducing the dose of cyclophosphamide, but in long term, there was always at least a tendency to higher relapse rates, as you can see here on data from Cycazarem study, and it was in fact significant in Cyclops. So it means that these patients who were treated with lower cumulative dose of cyclophosphamide in the beginning usually relapsed and had to be treated once again with cyclophosphamide, which of course finally increased the cumulative dose of this potentially dangerous drug. And it was shown in the analysis of UVAS that really early under treatment with low cumulative dose of cyclophosphamide, low cumulative doses of prednisone may be one of the major risk factors for relapses. So it was clear that we do not need to reduce cyclophosphamide, but to replace cyclophosphamide with some other drugs which could have similar efficacy but much lower toxicity. And it gradually appeared that Rituximab could be the drug of choice. And what was already known when the guidelines 2012 were prepared were the data from the largest study, Reich study, which randomized almost 200 patients with generalized AAV with mean eGFR 60 ml per minute. So these are not so much representative patients for vasculitis, because we nephrologists usually see patients with lower GFR. But in this relatively milder disease, the patients were randomized either to conventional treatment or Rituximab for remission induction. And you can see here that at 6 months, the Rituximab was non-inferior to cyclophosphamide, and it was even more effective than cyclophosphamide in reducing remission in relapsing patients. And there was no difference in adverse event rates in both limbs. In parallel, small but important study Rituximab was also published, it was important because it recruited patients with much more severe renal disease with mean glomerular filtration rate of about 20 ml per minute, some of them even requiring dialysis at entry. And in these patients, two regimens were compared, one based on traditional cyclophosphamide pulses and the second on rituximab in the so-called lymphoma protocol, combined with only 2 cyclophosphamide pulses. And here you see that even in these patients with very severe renal vasculitis, cumulative incidence of remission, sustained remission, and increase of GFR and 12 months was quite similar in both limbs. So this reduction of cyclophosphamide from 6 to 10 to only 2 pulses, accompanied by the common treatment, concomitant treatment with rituximab, was safe and effective. And this was already known in 2012, but the recommendation at the time was rather conservative, at least in my opinion, because despite this data on rituximab, it was recommended that cyclophosphamide and corticosteroids should be used as initial treatment. And rituximab and corticosteroids were recommended as an alternative treatment, and with the exception of the patients with severe disease, because it was believed that the data for rituximab in this subpopulation are insufficient. And even in terms of treating relapses, where I showed you that in Reich, patients treated with rituximab had better outcome than patients treated with cyclophosphamide, it was still recommended to treat the patients according to the same guidelines. So initial treatment should have been cyclophosphamide. And since then, some new studies or sub-studies of the older one studies were published and added new information on the efficacy and safety of rituximab. One of them was the sub-analysis of those patients from a Reich study who had renal involvement, and you see that even in this more severe population, the efficacy of rituximab was similar as that of cyclophosphamide. Then there were some long-term data. Long-term data from rituximab showed that those patients treated initially with only 2 pulses of cyclophosphamide and rituximab had in long-term caused the similar outcome as patients treated with traditional 6 to 10 cyclophosphamide pulses. And sub-analysis of data from Reich study show that especially patients with anti-PRC antibodies and especially patients with anti-PRC relapsing disease were very much benefiting from treatment with rituximab, and rituximab in these patients was more efficient, more effective than in cyclophosphamide. And the efficacy persisted after a long time after the treatment, in fact, was finished. And another study which also showed high efficacy of rituximab was published quite recently, and these were the data from the induction phase of Tesar study, which recruited only patients with a relapse of GPA or MPA. And all patients in this induction phase were treated with rituximab, and then they were randomized for the maintenance phase, either to rituximab and azathioprine, and I will show you these data a bit later on. And you see that in this study, rituximab was once again shown as a very effective treatment of relapsing ANCA-associated vasculitis, because 90% of patients achieved remission by 4 months, and only 3% of patients did not achieve disease control at 4 months. And also in terms of safety, we have now data showing that rituximab is safer compared to cyclophosphamide. These are the old data showing that there is a high risk of late occurring malignancies in patients with ANCA-associated vasculitis treated with high cumulative dose of cyclophosphamide. And we now know that it is not only more than 36 grams, but the risk starts somewhere between 10 to 15 grams of cyclophosphamide. You see that these patients had not only higher rate of bladder cancer, but also hematologic malignancies, and cancer at all sites was at least 2 times increased. And we have now data on rituximab coming from one center analysis in more than 300 patients. showing that really even in their hands, in the hands of Ingeborg Baiema and her collaborators, cyclophosphamide was associated with 3 times higher risk of malignancy, but rituximab had the same risk of malignancy as a control population. So at least in terms of late malignancy, rituximab is definitely safer. And now coming what we have in 2021 guidelines. We have here either recommendations where the evidence, ample evidence is available and systematic reviews were conducted, and where there is an insufficient evidence, but we want to provide some guidance, there are practice points, which were also used quite abundantly. And now starting from the clinical presentation and start of the treatment. What is stressed is that, of course, ANCA-associated vasculitis is often rapidly progressing disease. And it means that we can't wait for kidney biopsy to start treatment, and the treatment should be started immediately, especially when the results from kidney biopsy are not available within 1 or 2 days, which is sometimes the case. And concerning the treatment, and I will discuss it in greater detail later on, we see that rituximab is now considered as an alternative, or as a first-line alternative to cyclophosphamide, both in induction of remission and also in the maintenance phase. So you see the change. I already mentioned the relatively conservative approach to the use of rituximab in 2012 guidelines. And now you see that there is a recommendation that rituximab or cyclophosphamide with corticosteroid can be used as an initial treatment. So rituximab can be the first-line treatment even in new patients with ANCA-associated vasculitis. And there is, of course, a limitation because we still have limited data for patients with severe disease, and even in this population, the combination of rituximab and cyclophosphamide can be considered based on the data from Rituxvas. And there is also a table showing in which patients rituximab or cyclophosphamide could be preferred. I will not go through that in detail, but you see that there is really a limited advantage of cyclophosphamide. Cyclophosphamide is still recommended where rituximab is not easily available, and there is clearly a reservation to the use of rituximab only in patients with severe kidney involvement. And there's also a discussion if to prefer intravenous or oral cyclophosphamide. In our hands, we clearly prefer intravenous cyclophosphamide, but there still can be some place for oral cyclophosphamide, especially when there is an access to infusion center difficult, and also cost may be an important factor. What is also important concerning the induction phase is that it is necessary to reduce the doses of corticosteroids because they are associated with high toxicity. And this is based on the regimen used in PAXIVA study, when there was standard regimen of relatively high dose of corticosteroids and rapid tapering with about 50% lower cumulative dose of corticosteroids. And here you see that there was no difference in terms of efficacy, and there was a lower risk of severe adverse events, especially infections in patients with lower dose of corticosteroids. And so in the guidelines, the recommendation for all corticosteroid tapering is based on the PAXIVA's regimen. And as I already told, in terms of relapse, rituximab is now recommended as a preferable treatment, first-line treatment, which is different compared to 2012. Now, several words about plasma exchange. In 2012, the recommendation on plasma exchange was based namely on MIPEX trial, which recruited patients with severe renal vasculitis with serum creatinine of more than 500 micromoles per liter, and randomized them either to plasma exchange or methylprednisolone, and those patients who were treated with plasma exchange had better chance to be alive with independent renal function. And this was then compared in a meta-analysis. Plasma exchange had no impact on mortality, but there was a significant impact on the risk of ESRD, decrease of the risk by 36%. This was what was then stated in the 2012 guidelines, that plasma exchange should be used in patients on dialysis or with rapidly increasing serum creatinine, in patients with pulmonary hemorrhage, and also in patients in combination of anti-GBM and ANCA antibodies. But since then, some not so promising data appeared. Looking at long-term follow-up of VPEX, that there was no difference in proportion of patients free of ESRD or death, and no significant difference in the reduction of the risk of ESRD during longer follow-up. And of course, the most important data came from PEXIVAS trial, which recruited 700 patients with AAV and serum creatinine of more than 200 micromoles per liter, either to plasma exchange or no plasma exchange as an add-on treatment. And these patients were, of course, very different from MEPEX patients. They had milder renal disease, serum creatinine of only 300 micromoles per liter, and only 27% of them had alveolar hemorrhage, which was severe in only 9% of patients. And also there was a high proportion of patients with anti-peroxidase antibodies. And in these patients, there was no significant effect of plasma exchange on a primary endpoint of survival and end-stage renal disease. And this potential benefit of plasma exchange was not shown in any studied subgroup. So we still wait for another meta-analysis, and we still wait for sub-analysis coming from PEXIVAS. But based on this negative information, plasma exchange is no longer recommended. It's also in practice point stated that it could be considered in patients with rapidly increasing serum creatinine and diffuse alveolar hemorrhage, and also in patients with overlap Inkovasculitis and anti-GBM disease. Coming to the maintenance treatment, there was a detailed description of maintenance treatment in 2012 guidelines. Probably the most important recommendations are that it should take at least 18 months, and there were 3 options: azathioprine, mycophenolate mofetil, or methotrexate, or of course methotrexate only for patients with well-preserved glomerular filtration rate. And since then, we have data on the length of treatment and on rituximab as a maintenance treatment. And this important study called REMAIN compared to 2 different limbs, in which in one there was a long-term continuation of treatment up to 48 months. And in the second limb, there was an early withdrawal after 24 months. Of both corticosteroids and azathioprine. And you see that in terms of relapse rate or major relapse rate, this longer treatment, longer continuation was definitely highly significant. And it was shown that this relapse rate was high, especially in patients who were ANCA positive at randomization. And there was very importantly no difference in adverse events in patients treated with longer maintenance treatment. So it is benefiting, and it doesn't seem to bring another risks or other risks. And it was quite humbly stated that at least some patients who reach remission of ANCA-associated vasculitis benefit from long-term immunosuppressive therapy to prevent recurrences. And now coming to the role of rituximab as a maintenance treatment. The first important study published on this topic was Meinrich-Hahn, French study, which randomized more than 100 patients with ANCA-associated vasculitis in remission, patients with relatively mild renal disease with mean glomerular filtration rate of about 60 ml per minute to either rituximab or azathioprine. And you see that in terms of overall relapses and major relapses, patients who were on rituximab were in a much better position and had much lower rate of both these kinds of relapses. And once again, there was comparable rate of severe adverse events. And recently, data from the long-term follow-up of these patients show that this advantage of rituximab persists even during 5-year follow-up. There was significantly higher proportion of major and minor relapses in patients treated originally with azathioprine compared to rituximab. And what is also very much important, rituximab was even better in terms of mortality, and there was once again no difference in serious adverse events. And finally, I would like to share with you some not yet published data from Rituximab study. I mentioned Rituximab study in the induction phase of the lecture. So all patients were treated with rituximab in the induction phase, and those who came to remission were then randomized to rituximab or azathioprine. And once again, you see here that those who were on rituximab benefited in terms of any relapse, major relapse rate, and also they had even lower rate of serious adverse events. And here you see that there was really a different relapse-free survival. And we have now the last study published on the topic, which showed that it may be important for some patients to prolong the treatment with rituximab from 18 months to 36 months. These two limbs were compared in so-called MINRIT-SUN-3 study. And here you see that long-term use of rituximab was once again associated with significantly lower relapse rate and major relapse-free survival with no difference in adverse events. So what is now stated that compared to the old guidelines, which stressed the role of azathioprine, that we have now also rituximab for the maintenance of treatment, and that following rituximab induction, most patients should be treated also with rituximab maintenance. The optimal duration of rituximab maintenance is not clear. 18 months seems to be minimum, and some of the patients, as I showed, may benefit from longer treatment, and this longer treatment is also well tolerated. And once again, there is a table, once again discussing what is to be preferred, either azathioprine or rituximab. And azathioprine is once again preferred when there is a limited availability of rituximab, or possibly in some patients with low baseline IgG and or previous hepatitis B exposure. Finally, several words on complement inhibition. It is something which is beyond KDIGO 2021 guidelines, is still very much discussed. But the reason why complement inhibition was discussed was that from the previous studies, even with rituximab, it was apparent that there is no lower risk of cumulative incidence of severe adverse events in patients treated with rituximab, which was probably associated with high doses of corticosteroids in both limbs. And concomitantly, there was an accumulated evidence that complement may play an important role in ANCA-associated vasculitis, especially the activation of alternative pathway. Here you see that C5a and BB may be associated with the activity of the disease, and even more importantly, the activation of C5a receptor was shown to be associated with the crescent formation in experimental model of vasculitis. And then data from phase 2 trial showed that using complement C5a receptor inhibitor avacopan was really benefiting the patients compared to reduced steroid or high-dose steroid treatment in terms of early induction of the remission, in terms of early decrease of albuminuria, and also in terms of better quality of life. So this was the reason why phase 3 trial called Advocate was initiated. The study compared avacopan with the corticosteroids in both limbs. This treatment was added to either cyclophosphamide or rituximab. The study recruited more than 300 patients, and the primary outcome was remission, defined as BWAS score 0 at week 26 and sustained remission at week 52. And there were also some concern related to health quality of life and glucocorticoid toxicity. And here you see the results. The study was published this February. In terms of BVAS remission, avacopan was non-inferior to corticosteroids, and in terms of sustained remission at week 52, avacopan was even superior. And here you see the reason, because there was a higher relapse rate in patients who were initially treated with corticosteroids compared to those treated with avacopan. And there were some other benefits of avacopan. In my opinion, very important benefit was that there was a significant improvement in kidney function in avacopan treated patient, and it was better, and the increase was higher both at 26 and 52 weeks in patients treated with avacopan, and it was very much expressed, especially in patients with low presenting GFR. And there was confirming the data from phase 2 trial, additional benefit also in terms of health-related quality of life. So I am to conclude my presentation. So definitely rituximab becomes the drug of choice for ANCA-associated vasculitis, especially for patients with major relapses, but can be also used in patients with new ANCA-associated vasculitis. Rituximab is now clearly confirmed the best maintenance treatment, and it may have some additional advantages for in anti-PRC patients. On the other hand, we are now much more uncertain concerning the role of plasma exchange, and we need further elucidation. And avacopan should be a reasonable alternative to high-dose corticosteroids, but of course we also need more detailed data, and also we need the analysis in terms of cost effectiveness. Thank you for your attention.
All right, this was great. Thank you both, Vladimir and Heather. So we have a lot of questions, and we have about 10 minutes left. So I'm going to throw the first question out to Heather. I've been jotting some down, and this seemed to come up a little bit frequently. So Heather, you treated your patient with conservative therapy first, and then when the response was not really what we wanted, less than a gram, you also added steroids for a period of time, and they still didn't have a complete remission or even below 1 gram. So some of the audience want to know, one, what would you do next with this patient? And another member of the audience asked, well, if you have proteinuria left at the end of 6 months, therapy with steroids and IgA, would you consider prolonging the steroid therapy with lower dose prednisone?
Thanks. These are really important questions, and I think truly unmet needs. So this is all personal practice.
Heather, you froze. Shoot.
Call them recommend. I won't even call recommendations, but personal practice. A little weird.
Okay.
Are you able now?
Heather, you're coming in.
Are you able to hear me now?
Yeah, we can. You're coming in scattered a little.
I'm not sure. Okay. I'm going to, while I'm talking, I'm going to try to set up a VPN, a virtual hotspot.
Okay.
So these are really the limits of our knowledge right now. And I think this is a perfect instance where something like SGLT2 inhibition would find a niche, and really trying to use other less toxic methods to reduce proteinuria and confer nephroprotection. I definitely don't think I would extend the steroid exposure. Truly, if it's going to work, it's going to work. There are responders and not responders, and that might reflect whether we're dealing with proliferation versus fibrosis. And so I don't see any benefit to extending corticosteroids. So potentially in the future, we'll have different agents that have different mechanisms of of action. Ideally, we would have some biomarkers that would allow us to differentiate and distinguish fibrosis versus proliferative activity. But I think this is potentially where the niche is for the enhanced conservative therapy and medications that work by different mechanisms than prednisone. There's no use beating it over the head with more prednisone.
Okay. All right. Thank you, Heather. So I'm going to throw one out to Vladimir. I think these are two basic questions that are really important, and I'm going to loop two together. One of the audience members asked, is it okay to use Rituximab for maintenance therapy if you induce an Inkovasculitis with cyclophosphamide? And then sort of not aligned, but what about Rituximab in pregnancy for Inkovasculitis? Are there any data on pregnancy and Rituximab?
Yeah, the first question is much easier. Yes, we can use it. I must admit that at least in my center, most patients who are now treated with maintenance, Rituximab maintenance, were already treated with Rituximab induction. But especially in the past, there was a significant proportion of those who were induced with cyclophosphamide and were then treated with Rituximab, and it works, of course. Yeah. So this is only a suggestion that it is better to stay with Rituximab than to switch from cyclophosphamide to Rituximab, because in fact it doesn't make sense. If you have Rituximab available, why to start with cyclophosphamide and then switch to Rituximab? But it's possible and it works. Concerning the gravidity or pregnancy, it's really difficult. The experience is limited. So there is a very different approach to the treatment of patients with different monoclonal antibodies, also in other autoimmune diseases. For instance, some patients with inflammatory bowel disease are treated with different monoclonal antibodies, also in pregnancy. But with the limited availability of evidence with Rituximab and with the option that there may be some impact on the fetus, I would not recommend it, with the exception of the situation where this is something like life-threatening disease and there is no other option.
Okay, very good. Thank you. And I'll just say in our own practice, we tend to induce with cyclophosphamide and then maintenance therapy with Rituximab. Okay, Heather, let's see, there's plenty of stuff here. Here's a very interesting question. And I think you need to emphasize this. If you're looking at the MEST score, would a T2 be a negative indicator for you for using steroids in the treatment of IgA?
Well, I'll say that I really hope that in the future we're going to see some pathology data in some of the new randomized trials. For instance, the complement drugs, T2 is sometimes an exclusion for randomization. So we're not going to see a lot of patients in clinical trials with T2 reflected. And so this is going to be a personal decision and patient specific. When there's significant disconnect between T2 and the clinical variables like proteinuria and which remains high, and creatinine, which may be okay, you do have to wonder about sample bias. And so, maybe you just happen to sample a section where there was more fibrosis if the GFR looks okay and there's still reason to treat. So on its own, I would not use it as an exclusion, but it should be coincident with, it should be considered in association with proteinuria and GFR. The other factor of utmost importance, of course, is the patient risk factors. So they've already had course of steroids, they have a high BMI, they have diabetes, their GFR is under 30. When you consider that with the T2, you're starting to really lean against using corticosteroids.
Yeah, and I'll just add to that in our own experience with the clinical trials. As most of you know, the ones that are starting to show data really didn't include a concomitant biopsy requirement for entering the clinical trial. So it's a really interesting question, and I have to tell you, a lot of these patients had IgA for a long time, so my guess is some of them had a more advanced interstitial disease, and it would be really interesting to see, maybe even with repeat biopsy, if some of the responders actually had T2 lesions. Okay, back to Inkovasculitis. One of our audience members said the MEPEX trial had a higher serum creatinine and BVASC score in general than the patients in the Pexavasc trial. And they're wondering whether you would still consider plasma exchange in those patients who present with a serum creatinine greater than 500 micromole per liter.
As I already stressed, the data probably are now not so strong as they were before, because they were partly voted. The original idea of Pexivas was that the benefit of plasma exchange could be extended to the population of patients with serum creatinine between 200 micromoles to 500 micromoles per liter, because there were data showing that especially if these patients are also anti-PRC positive, they can benefit. So it doesn't seem to be the case. And there is no reason why using plasma exchange in this subpopulation, probably with the exception of very active disease and progressing disease on biopsy and a steady increase of serum creatinine. Otherwise, in terms of MEPEX-like patient, we still use plasma exchange in most of them, and we are still waiting for the other analysis. And I think that plasma exchange still remains an important option for some of these patients. For instance, when you have a patient in the intensive care unit with a combination of alveolar hemorrhage and severe pulmonary infection, there are limited options what to do, and plasma exchange can be quite safely done and can improve the outcome of the patient.
Okay, and Vladimir, I'm going to throw you one more question, and I don't know if you're going to be able to answer it, but this is a really hard question. What is the reason people fail given Rituximab in Inkovasculitis? So why doesn't Rituximab work in some people? You want to take a stab at that?
So you mean why it is not so frequently used, yeah? Or why,
no. Why may it not be effective? They want to know the pathophysiology here.
Yeah. Of course, generally in the beginning, there was not a great belief in Rituximab, because it was always believed that ANCA-associated vasculitis or mostly T-cell mediated disease. Yeah? And it is. Yeah? So for instance, granuloma are definitely related to T-cell activity. And it was a surprise when first data from Mayo appeared and showed that really Rituximab may be so effective in these patients. And currently, I think that we are even in some kind of trap, because Rituximab is so effective that it closes the window for other trials, because it's almost unbeatable. It's something like with ACE inhibitors and other drugs which could compete with it in terms of conservative treatment. There, in our hands, we have a very positive experience. We have something more than 100 patients with vasculitis treated with Rituximab, and it is effective in almost all of them. Yeah? So some patients may have some complications which are also rare, and there may not be such a good response, for instance, in patients with bronchial stenosis or some other granulomatous presentations, but these presentations do not respond to cyclophosphamide too. So it is usually the failure in very resistant patients or very refractory patients to everything. But generally, it's a great surprise for me, and the experience is very positive. And this is the reason why, for instance, David James suggests that in vasculitis, it is not necessary to look at anything. For instance, you do not need to confirm that the patients are really B-cell depleted, because it works. And you should look at the presence of B-cell depletion only in those patients who are not responding, which is definitely not the case, for instance, in membranous nephropathy or in lupus nephritis, where the success rate is not so high, and we should be clearly sure that there is a B-cell depletion in these patients.
Okay, well, that was a great answer for this really hard question. All right, let's finish up with our last question to Heather, and I thought this was a really cool question. Heather, when IgA nephropathy starts in children and then they transition to adult care, is their care different, or do they behave differently than folks who got IgA nephropathy as an adult?
A great question, and I work across the street from the largest pediatric hospital in Canada, so I get a lot of transition patients coming to us from them, and there are some trial data. There was actually some data from a study from Israel as well that looked at persistence of microscopic hematuria after child illness and developing overt proteinuria. And I do think we underestimate the frequency with which pediatric patients who have, I'd say probably more commonly IgA vasculitis, but who have IgA nephropathy and vasculitis that appears to remit nicely, but then really do develop persistent proteinuria and for all intents and purposes look like pretty bad IgA. And so I do see a lot of progressive disease later in life. And do I treat differently? No, but I think that sometimes we tend to undertreat the pediatric and teenage population when they transition to adult care. So for example, the concept of putting a 19-year-old on a statin when their GFR is 40 and their LDL is 2.5, is kind of foreign to people. So I would say that I'm very aggressive with this population, but rather than say it's different than adults, I would say I treat them the same, and that itself might be different. And so I do think there needs to be a recognition that these patients may progress. The other variable I think I'll just bring up is female patients who have had IgA nephropathy as children. You will, if you just look at eGFR, you're going to underestimate the amount of kidney injury they have, and that's going to be a problem when they decide to get pregnant. And so really keeping an eye on female patients who have a history of IgA nephropathy as in childhood, and making sure that their disease is very aggressively controlled and that they have very good management and risk stratification when they want to conceive.
Okay. Well, listen, everyone, this was a great conference. I really want to thank our two speakers who really stimulated a wonderful discussion. The audience was clearly engaged with many more questions that we couldn't get to, but we will try to answer some of these questions through email. I would like to thank the International Society of Nephrology and the KDIGO organization for putting this together. And stay tuned because as you may know, we're going to do a part 2 where we're going to discuss lupus and FSGS, and that'll be a very exciting discussion as well. So I hope to see the audience back for that, and have a nice weekend, everyone. Bye-bye.
Bye-bye. Bye.